You're listening to On the Frontlines of CIDP on ReachMD. On this episode, we'll discuss the mechanisms and diagnosis of chronic inflammatory demyelinating polyradiculoneuropathy, or CIDP, with Dr. Hans Katzberg, who is a professor of medicine at the University of Toronto. Let's hear from Dr. Katzberg now.
CIDP is an immune condition, and similar to other neurological immune disorders, the immunological mechanisms are complex. The primary target is the myelin sheath, the insulation that covers the peripheral nerves. And essentially, there is an erroneous message where there's certain antigens on this myelin sheath that trigger autoreactive T cells to infiltrate the peripheral nervous tissue. And then this begins essentially a targeted inflammatory response characterized by elevated cytokines. Some of these are TNF-alpha, interferon, gamma, interleukin-1, and this promotes inflammation and recruits additional immune cells. These include macrophages, which are then activated by the cytokines, and this essentially phagocytes or eats up the myelin sheath components. So this strips away essentially the myelin sheath and leads to the segmental demyelination that occurs. In more recent years, there's been some antibodies that have been discovered that are actually targeted against nodal and paranodal proteins. These are not exactly on the myelin sheath, but allow an attachment of the myelin to the nerve, and this can then destabilize this architecture and also lead to similar conduction slowing and blocks. But technically, according to the new classification, this new IgG4 antibody-mediated diseases are not considered CIDP. So genetic and environmental risks has been looked at over the years to see if some of these might predispose to CIDP. And in spite of all this work, it appears to be primarily sporadic as a condition. There's been certain genetic predisposition that have been recognized, for example, HLA haplotypes, such as HLA-DRB113, HLA-DQB1. And there's also been some genetic associations, including polymorphisms in certain genes that might regulate inflammatory cytokines and other cell-mediated immune responses. And environmental triggers, there's a number of them that have been linked to CIDP, and this includes similar triggers that have been linked, for example, to Guillain-Barré syndrome. So infections, viral or bacterial, surgeries, vaccinations, and other stresses to the system that may activate the immune responses. However, despite these associations, direct causal pathways really have not been confirmed, so there's ongoing work in this field. So the clinical features that raise suspicion for CIDP, in contrast to Guillain-Barré syndrome, which is a very acute neuropathy, is a more of a chronic presentation. In fact, it's in the name. CIDP stands for chronic inflammatory demyelinating polyradiculoneuropathy. So greater than 2 months of progression is usually what we use as a cutoff to distinguish it from Guillain-Barré. And then the hallmarks are progressive symmetric muscle weakness, as well as distal weakness. And this can also be associated with hyporeflexia or areflexia, which indicates some of the characteristic features of demyelinating neuropathies, and also sensory symptoms, numbness, tingling, paresthesias. Neuropathic pain, I think, is less common than in Guillain-Barré, but can happen. The progression is usually, or the pattern rather, is usually progressive or with a relapsing remitting type pattern, and this can be mitigated by treatment, particularly early on. So the EF and SPNS guidelines have been critical and very helpful over the years in order to confirm a diagnosis of CIDP. So this integrates clinical, electrophysiological, and supportive criteria, which could include laboratory criteria or testing or neuroimaging as well. You want to make sure that you're fitting the clinical criteria of more than 2 months of progression of motor and sensory deficits. And then the electrophysiology, I think, is key. That's where you want to be certain that you're having demyelination as part of the pathologic process, and there is certain criteria for those nerve conduction studies. For example, slowed nerve conduction velocities below 70% lower limit of normal, prolonged distal latencies greater than 130% of the upper limit of normal, and conduction blocks. And to be certain that one is experiencing that more than 50% reduction usually is considered helpful. The other paraclinical tests that I mentioned, CSF, can show elevated protein with white cell counts below 10. And then also, as I mentioned, imaging. So MRI, showing inflammation when gadolinium is administered, or ultrasound, which can show increased cross-sectional area, can also be used as supportive criteria in addition to the more core clinical and nerve conduction criteria.
That was Dr. Hans Katzberg talking about the mechanisms and diagnosis of CIDP. To access this and other episodes in our series, visit On the Frontlines of CIDP on ReachMD.com, where you can be part of the knowledge. Thanks for listening.